Hello learners and welcome back. My name is Dr. Leah Kaler. I'm a licensed clinical psychologist and prescribing psychologist. Today we are going to be talking about substance use disorders, trauma, and co-occurring conditions. We are going to start by looking at the history of traumatic stress. We're going to move forward in time to our current post-traumatic stress disorder criteria. We're going to be exploring attachment theory, adverse childhood experiences, and multicultural considerations. When looking at the history of traumatic stress, it's important to recognize pioneers in the field, such as Pierre Janet and Abraham Canier. Each individual had a significant role in looking to recognize post-traumatic stress disorder, identifying key trauma phrases, and also establishing the diagnostic criteria for the diagnosis and treatment of post-traumatic stress disorder, PTSD. We must also look at the fact that PTSD was initially introduced by the American Psychiatric Association in the DSM number 3 all the way back in 1980. All said, this is not necessarily a new diagnosis or a new lived experience to explore, but I do think that it continues to evolve with increasing knowledge and understanding of one's lived experience and trauma and how to effectively treat trauma. So when we see these initial diagnostic criteria from 1941, we can still see some evidence of this in our diagnostic criteria today, which we're going to be looking at the DSM-5 text revision. And such persistent startle response, irritability, explosive outbursts, aggressive behaviors, the fixation on the traumatic event, construction of one's general level of personality functioning, and then also recognizing that there are disturbances in the functioning and atypical dream life. That was in terms of dissociation as an example. So today we see pieces of this, but it has again evolved with knowledge and understanding and additional research. As we move forward to today, we look at PTSD as post-traumatic stress disorder. PTSD is diagnosed if the symptoms interfere with daily life and continue for at least 1 month. Symptoms of PTSD are classified into specific categories, such as avoidance, where one stays away from people, places, or things that are reminders of the event. The next category is re-experiencing. This encompasses flashbacks, frightening thoughts, or nightmares. The following category is arousal and reactivity, and this may encompass difficulties in sleeping, being on edge, feeling angry and having angry outbursts, or being easily startled or distracted. And you can think of someone being very hypervigilant in this category. Next is cognition and mood. So this person may have distorted feelings of guilt, negative self-image, issues with memory, and maybe they just don't enjoy activities that they previously really loved. So for emotional reactions to the traumatic event, we often see fear-based re-experiencing emotional and behavioral symptoms present. We may see anhedonia or dysphoric mood, which can very much be present along with the dissociative symptoms, and a combination of the aforementioned is not unrealistic to see. So there is a prevalence of PTSD and addiction, and that is about 50 to 66% of those who suffer from PTSD. They also battle simultaneously with addiction, and the reverse is also true. So here we're seeing if an individual is in fact diagnosed with a substance use disorder, it is that lived experience that they are 50 to 66% more likely to suffer from some type of traumatic symptom. People who suffer from PTSD are between 2 to 4 times more likely to also battle with addiction compared to their peers who do not struggle with PTSD. We know this from lecture 1. PTSD can change brain chemistry much the same way that substance use and addiction do. Often these disorders form at the same time and feed off of one another. The same trauma that caused the PTSD can also be the same trigger for substance use. And following that traumatic experience, the brain produces fewer endorphins, which is one of the chemicals that helps us to feel happy. People with PTSD may turn to alcohol or other mood-enhancing drugs to increase those endorphin levels over time. However, the drug will always go into a withdrawal period, and when that happens, the person is reliant on going back to some type of substance to relieve those feelings of depression and anxiety and irritability that may come along once the drug wears off. It's important to note here that this idea of being normal or at one's baseline with trauma and continuous substance use, that baseline very much might change. And the person may need more and more of that substance to just make it back to what their original baseline once was. It's okay to recognize that things may start to look different based on the brain's changing experience because of trauma and because of the substance use disorder. So we have a situation here where we say an individual has experienced a traumatic event. So let's take, for example, 9/11, where many, many people all around the world experienced a very profound trauma. When you have people experiencing the same event, we must recognize that each individual will experience that traumatic event differently. And because it is experienced differently, each will have a different stress response that is unique to them. This is one of the challenges to identifying and studying traumatic stress. However, when we look at this response to the challenge, SAMHSA, which is the Substance Use and Mental Health Services Administration, they had conveyed a group of academics and clinicians, and they came up with this idea of the 3 E's to define trauma. And the 3 E's articulate what we're talking about. So the idea that trauma comes along in 3 aspects, such as the event, the experience, and the effect. The complexities of these 3 interrelated components are what should be considered the clinical work and studied in research. The event, the experience, and the effects will lead us to this unique individual experience, even if it was shared traumatic event. As such, characteristics of trauma, we look at trauma resulting from one event, a series of events, a set of circumstances, or real-time trauma. Again, if we think back to 9/11, this was a real-time trauma, but even if we weren't in New York City at the time of 9/11, we did experience real-time trauma through social media, news channels, so everyone's experience around this event and its effects are going to look somewhat different. Experienced by an individual as physical or emotionally harmful. Now, this goes back to the idea of real versus perceived threat being a characteristic of trauma, and that is where we do a piece of our work in the clinical field. Lasting adverse effects on one's individual, physical, social, emotional, and spiritual well-being. Lasting adverse effects and a physical realm could be that somebody was physically injured, say in a car accident, and they might have those physical effects of the trauma ongoing. Socially, social groups could change. Emotionally, the idea of being happy starts to look quite a bit different. Or maybe spirituality, we start to question our spirituality or our religion or higher power based on these events that have occurred. When we consider the signs and symptoms of trauma, there was a very large list of signs and traumas here, such as anxiety, withdrawal, irritability, increased sensitivity, physical symptoms, substance abuse, changes in sleep and appetite, startle response, thwarted attention, that's your fight, flight, or flee. Also, altered state, this is a very traumatic disassociation where one might be daydreaming or start to truly dissociate in that moment, and the body memory starts to respond and reactivate in the experience of flashbacks and nightmares. So when we look at the signs and symptoms of trauma, I challenge you to look at these signs and symptoms and see which of these might be a result of substance use disorder. We know that if an individual is drinking alcohol and withdrawing from alcohol, the side effect of the half-life of alcohol is anxiety because alcohol is a depressant. So when an individual starts to withdraw from alcohol, their anxiety will naturally increase and to become potentially irritable, and this is not uncommon. And this could be for many other withdrawal periods of other substances as well. In those who use stimulants, they can become highly irritable at times. We know that individuals who engage in substance use also have increased sensitivity. They may become physically ill because of withdrawal symptoms, and there are disruptions to sleep and eating cycles. So all of these symptoms can very much mimic substance use disorders and or be symptoms of traumatic events. It's important that we start to work with individuals to see the onset and what might be a primary concern for them so that we can start to address the issues at hand here and now in a very effective manner. People who have experienced trauma are very much more likely to engage in substance use as a maladaptive coping skill. They are also more at risk of suicide, more likely to use tobacco, more likely to have occupational problems, and to experience depression. They're also more likely to take antidepressants or other types of medication prescribed by a doctor. They may be more likely to inject drugs as well. Because of high-risk behaviors, it's more likely to develop sexually transmitted diseases. There's also a profound connection between trauma and addiction that leads to maladaptive coping life choices that engage in high-risk behaviors as a result of poor judgment. When we talk about trauma, we recognize that trauma could very much stem from childhood. It doesn't necessarily have to be one particular traumatic event or a series of events, but when a child does experience traumatic events, this has a lifelong effect, and we need to look at what it means in our work here today. So what happens when something occurs, such as a trauma in childhood, that does not always stay in childhood? How does this apply to co-occurring conditions? You're gathering information around trauma and you're looking at PTSD signs and symptoms. We're starting to see the co-occurring conditions between trauma and substance use disorders. And when we look at childhood experiences, it helps us to identify a little bit more of what might be happening with an individual to improve our ability to provide effective care for them. So let's start by looking at attachment theory. When we consider attachment theory, there are 4 types of attachment styles. It's important to recognize the depth of each of these attachment styles as we conceptualize one case in order to understand their experience, their worldview, and how treatment needs to be wrapped around them in a way that's effective and productive. Let's start with secure attachment. Children who experience secure attachment can depend on their caregivers, and they show distress when separated, but joy when reunited. Although the child may feel upset when separated from the caregiver, they feel assured that the caregiver will return and be able to keep them safe and comfort them. When a child that experiences secure attachment is frightened, they are comforted and seek assurances from their caregiver and ask to seek support outside. Next, let's look at avoidant attachment. Children that experience abuse to some degree or have some type of rupture in attachment, these children under ambivalent attachment styles become very distressed when the parent leaves the room. They consistently stay upset. They're very distressed and they remain distressed even whenever the parent comes back. As a result of poor parental availability, these children cannot depend on the primary caregiver to be there when they need them. Oftentimes, you'll see individuals transition from this type of attachment style into their adulthood when they start to form relationships and romantic relationships. Maybe they pull away from others if they feel they're getting too close or fear of having someone leave them before they can manage that. They want to gain control of the situation so they're not depending on anyone. They may have a fear of getting too close or being too attached to someone. Next, let's look at avoidant attachment styles. These are children with very consistent states of hyperarousal. They don't seem to care when the parent leaves or when the parent returns. The child with avoidant attachment tends to avoid parents and caregivers. They really don't show a preference between a caregiver and a complete stranger. They're more likely to take on the role of a bully when in a school situation. And then as we transition into adulthood, they will often target others who have an ambivalent or anxious attachment style. This attachment style may result in abusive or neglectful caregivers. And then lastly, disorganized attachment. These children display a confusing mix of behavior. They are seemingly disoriented, dazed, or confused. They may avoid or resist the parent. They lack a clear attachment pattern, and this is likely linked to inconsistent caregiving. So this sense of being disorganized comes from a disorganized caregiver in many aspects. And as such, parents may serve as both a source of comfort and fear, leading to this disorganized attachment and disorganized behavior. I encourage you to watch the Still Faces experiment. I will link it down below. And this speaks to attachment theory and how the impact of childhood development and the attachment that they form continues to be with us throughout the lifetime. As we start the conversation about childhood trauma, it's important for us to look at the ACEs study. ACEs stands for Adverse Childhood Experiences, and in recognizing the impact of ACEs on one's lifespan, so the ACEs study was conducted by the CDC and Kaiser Permanente. The ACEs study was one of the largest investigations of childhood abuse and neglect and household challenges in later life, health, and well-being. So this is one of the very first and one of the largest and ongoing studies to say that what happens in childhood and what happens in one's home can really have a significant impact on their later life and well-being in multiple ways. So let's talk a little bit about what we see here. The original study was conducted by Kaiser Permanente. It started in 1995 to 1997. But again, this study continues to evolve and to grow, and we're learning more. What we do know is that individuals who experience ACEs are much more likely to develop depressive symptoms, anxiety disorders, have physical health conditions, and are very much impacted long-term for their development, their health, and their well-being. About 61% of adults surveyed across the 25 states through the ACE survey reported that they had experienced at least one type of adverse childhood experience, and nearly 1 in 6 reported that they had experienced 4 or more types of ACEs. Some children are at greater risk than others, and some women and certain racial and ethnic minorities are also at a greater risk of having experienced 4 or more types of ACEs. Individuals that have experienced ACEs are at an increased risk of attempting suicide. Individuals that have scored 4 or more on the study are 7 times more likely to have alcohol use disorders. Individuals that have scored a 6 or more on the ACEs study are more likely to engage in IV drug use. Preventing ACEs could potentially reduce a large number of health conditions. For example, 1.9 million cases of heart disease and 21 million cases of depression could have potentially been avoided by preventing ACEs. ACEs are also extremely costly. The economic and social cost to families, communities, and society totals billions of dollars each year. So, we start to understand the complexity of addiction, stress, and trauma, and we're looking at attachment theory and traumatic symptoms and events, but we must recognize the impact of ACEs as well and work to integrate our knowledge to inform our approach in working with individuals that have experienced adverse childhood experiences. As we move on to look at this interconnectivity, we're going to explore co-occurring conditions. This is a very important piece to recognize in that the individual has a co-occurring disorder. They may have a disorder that exists independently of the addictive disorder. So when we talk about substance use disorders, we know that individuals would likely have a preoccupation with the drug that would continue, and they're going to continue to use despite adverse consequences. That there's going to be tolerance and a progression in their use as well as withdrawal symptoms. When we look at a psychiatric disorder, there's a collection of symptoms that are pathological or abnormal psychology and certain diagnostic criteria when we see one experiencing. It's important for us to work with individuals to help them get clean and sober in order to see if a psychiatric diagnosis is independent of the addiction disorder or not. It's very difficult to do that, as you might imagine, because oftentimes people struggle with pre-contemplation stages of change, and there's often denial associated with drug use, especially in early stages of one's recovery. There's also the idea that, of course, people can relapse. Relapse is not expected, but it can and does occur. So even though somebody might be working towards abstinence or engaging in harm reduction behaviors, they may still be going back to the drug of choice or abusing another mood-altering substance or chemical because there's habit involved, and they really need to engage in a supportive network that will help to address recovery. When we look at co-occurring conditions, we often see in the field that people are diagnosed with co-occurring disorders. However, I really wonder, does it truly exist, or are we seeing substance use disorders mimicking psychiatric disorders? Are we seeing that individual that has alcohol use disorder also being identified as a candidate for anxiety disorder? Because they do have symptoms of anxiety, but the question becomes, is that anxiety a result of alcohol or post-alcohol acute withdrawal symptoms? Or is the anxiety independent of alcohol on its own? So it gets to be very complicated, as you can see. So it takes time and persistence and very much motivation and effort to continue to work through this type of progression to determine what is a co-occurring condition, what is not, and then we formulate our care for the individual presenting with these symptoms. We must also recognize that psychiatric disorders can very much mimic substance use disorders. So for an individual who might be presenting with a dissociation, the individual might be presenting as highly anxious, and we might question whether or not they have abused a mood-altering chemical. Is this a result of that mood-altering chemical? So we can see how this works in tandem, and it's important, again, for us to take time and energy to help pull this apart, to dig deep with the individual, to provide a safe place for them to be open and have conversations. And again, this might be challenging, but it's also highly rewarding once we understand what the symptoms are a result of. It's not necessarily what came first, like the chicken and the egg, but it is important to offer effective treatment, the ability to discern what is the primary condition and what do we need to address first so that we're not misdiagnosing an individual and providing them with inappropriate care that could ultimately harm them. The National Survey on Drug Use and Health in 2020 identified that 9.5 million people have a mental illness as well as a substance use disorder. Again, I'm not going to debate these statistics by any means, but I do wonder what this looks like. Are some of these symptoms being mimicked? Are people being misdiagnosed with co-occurring conditions? All of these 9.5 million people have a co-occurring condition, but only 7.8% received both substance use disorder treatment and mental health treatment. This is a very low statistic and a very scary thought. So we recognize that 9.5 million people have these conditions, but very few of these individuals are actually receiving some type of co-occurring, integrative, collaborative, concurrent care. It's estimated that 3.6 million people have both a severe mental illness and a substance use disorder. And here we're seeing only 12.7% receive both substance use disorder and mental health treatment. So when we're looking at severe mental illness, the number of individuals that receive treatment is slightly higher. I'm going to assume that this is likely because of levels of care and individuals functioning, requiring medically monitored treatment at a higher level of care. The vast majority of individuals receive no treatment. So we're talking about these low numbers of people who did receive substance abuse treatment and mental health treatment, but we can't ignore the fact that a great deal of individuals are receiving no treatment at all. We have our work cut out for us, and it's important that we recognize so many of these signs and symptoms that we're discussing here today to engage and to be advocates for individuals who are ill so that we can help them manage and engage in the process of recovery. When we look at the prevalence of co-occurring conditions, let's look at gender first. Although men made up more than 50% of Americans with co-occurring conditions, more females than males receive dual diagnosis treatment. Some of this also stems from our culture, our identity, and how one grows up with the idea of when a little girl falls down and gets hurt, and their family might be more likely to run over and pick her up and say, "Tell me what happened, come here, let me hold you." In comparison, if a little boy falls down and gets hurt, their family may be more likely to say, "Get up, dust yourself off, and just tell them that it's going to be okay and to get back out there." So think about how we treat our children. What are the systemic and cultural concepts that influence our system and develop this culture of what's appropriate for one's gender versus another, and how that may have residual effects that fall into one's ability to receive treatment and to seek help or not? Overall, males are more likely to have higher rates of substance use than their female counterparts in the United States. The prevalence of mental illness is higher for women than men. However, the rates for men and women are very similar for co-occurring conditions. Males are more likely to suffer from antisocial personality disorders, while women are more likely to have higher rates of mood and anxiety disorders. Individuals with substance and anxiety disorders are twice as likely to suffer from substance use disorders than those with other disorders. So why is this important? And we question, so what? I think that the answer becomes this is important to recognize so that when you're in a room with an individual, you're working with this person, you have this backdrop in your mind that you can use to help you, again, conceptualize the case, maybe ask more pointed questions, and engage in an appropriate, culturally responsive type of treatment to ensure that we're looking for the right things, we're asking the right questions, we're getting the right information, and we're hopefully providing them with a safety net to seek recovery in an effective manner. Now let's talk about the prevalence of co-occurring conditions in priority populations. And these populations are homeless, veterans, criminal justice involved, women, and adolescents. With regard to homelessness, approximately 568,000 people experienced homelessness in the U.S. on any given night. This is an epidemic in our society, and out of those individuals, 29% present with co-occurring disorders. So that's what COD means in the PowerPoint, co-occurring disorders. Veterans. 37% of veterans experience homelessness and present with co-occurring disorders. So the rates among veterans is higher. And when you look at the number of veterans who are in fact homeless in our society today. With regard to criminal justice involved people, 60 to 87% of the estimated 10 million incarcerated individuals have co-occurring disorders. When we look at women, 3.4% of women have a co-occurring condition, and these co-occurring conditions are more likely to be homelessness, unmarried, having a history of physical or sexual abuse, having more barriers to employment, having more medical conditions, being on more psychiatric medications, and receiving public assistance compared to their male counterparts. With regard to adolescents, 1.7% of adolescents between the ages of 12 and 17 have both a mental health issue and a substance use issue. As we take all of this into consideration, we're looking at multicultural competency. So when we're working with individuals, we are able to feel confident in working with a diverse population. And we have some information to go forward and help inform this process. We recognize that marginalized groups face systemic, organizational, cultural, and attitudinal obstacles to cope with co-occurring condition treatment. This is a result of the fear of stigma and feelings of shame, mistrust of providers, which is deeply rooted in our history, language barriers, logistic obstacles such as transportation or having childcare, fear that the provider will not be culturally competent and culturally responsive, and that they're not like me and they're not going to understand me. Perhaps it's lack of insurance. There's limited access to treatment and utilization of treatment, and this may very much be based on geographical region. Not believing that treatment is warranted. And culturally, this might be something that is not well received, as well as family approval. Going back to our schema development and worldview, how does our family view of treatment and what that looks like? How have we learned about treatments? Think about pop culture as an example and what people might perceive as treatment, and maybe it's not for them. So we're working to break down these systemic, organizational, and attitudinal barriers to treatment. I provide this graph, and it is to identify racial and ethnic disparities in relation to severe mental illness. It clearly speaks to the idea that marginalized groups are definitely experiencing life much differently than non-marginalized groups. They are more likely to be diagnosed with more severe conditions, more likely to be having higher doses of medication prescribed to them. And ultimately, we have to do a lot of work in our field about finding balance and being culturally sensitive in our approach to treatment and ensuring that we're providing appropriate treatment and not letting implicit bias take over. So, advice to the counselor using culturally appropriate methods. There's a list of recommendations here to provide culturally appropriate co-occurring condition treatment, and that includes adapting our interventions by altering the content of the materials. Much of our assessments have been developed by individuals who are Caucasian, middle-aged males, and throughout history of the counseling profession, this is very prominent. Is this something that we can look at to identify more age-appropriate racial and ethnic groups to be able to engage in materials that fit the culture versus another cultural view that might create harm? Maybe we need to translate the materials. We might need to call an interpreter. It is possible to tailor our services and culturally match counselors to clients to have that shared experience if at all possible. And when we're able, implementing programs directly in the community where the client resides. The traditional approach of the brick and mortar office and the client coming to you for treatment, this is starting to fall to the wayside. We're trying to move towards more boots on the ground approach where we are reaching more people by being out in the community and taking into account the client's cultural beliefs about mental health, substance abuse, and health-seeking behaviors, and the causes of the problem in our approach to treatment. So we ask these questions to help me understand. I'm interested in hearing more about your experience and what your thoughts are about this, and we can use that information to tailor a treatment in a very profound way. Finally, a culturally competent and integrated treatment and approach includes being aware of cultural and ethic bias in one's ability to work with another person. How might this influence your diagnosis and your treatment? This concept of services being offered through a single, unified, comprehensive system, which would allow for more holistic, integrative care services to match the intensity of disorders and the intensity of the treatment intervention. Again, we have this no wrong door policy. A community-based treatment setting is consumer-centered, no matter how the individual enters care and how often the services are there to respond effectively to co-occurring conditions. Lastly, I'd like to take a moment for final thoughts and reflections. We covered a lot of information here today. I encourage you to write in the comments or reach out if you have any questions and you'd like to have a further discussion about all of this. Again, thank you so much for your time, and I hope that you found this lecture helpful.